Hi, and welcome to the Vet Dental Show. We have this month Dr. Victoria Lukasik, who is boarded in anesthesia, who has done a course for us that is about anesthetic safety in veterinary dentistry. And we'll be taking segments from this course for the podcast for the next month. So I know you're going to enjoy this. Super impactful. It will probably change the way you practice anesthesia during your dentistry procedures. And at the end of each episode, we'll have a special link for you with a promo code where you can get this course and our other dentistry courses at a huge discount for this month. Hope you enjoy.
So here's Kodiak. Kodiak is obviously Siberian Husky. So again, I'll ask, what's our clinic going to sound like today? It will probably be really loud and probably really exciting because Huskies are so full of energy. So he is coming to us today because he has a fractured lower canine tooth. And I didn't see it until he was asleep. And he's so wiggly and he's so excited that the client just said, there's a tooth there that's broken. No one knew how severely it was broken. So we weren't exactly sure what we were getting into. But he's 14 months old and he is full of energy. So his physical exam is relatively unremarkable. So for our attendees who are not in the traditional English units countries, there's some centigrade for you. So 39.1 C, which is 102.4 Fahrenheit. Now he is not unexpected to be a little hyperthermic right now. His pulse rate's 132, his respiratory rate is 24, and he is jumping and he is talking and he is all over the place. His pre-anesthetic laboratory testing is all within normal limits, except his phosphorus is slightly elevated at 6.6. Now, at 14 months of age, that's a little bit old to have puppyhood elevations in phosphorus. So we have to think for a minute. Is this a meaningful thing that this phosphorus is slightly elevated, or could it just be normal for Kodiak? So what's interesting about how bell-shaped curves are created to make normal ranges for laboratory work is that we have a whole bunch of values that are placed into the pool of normal values, and then 10% or 5% are eliminated from the top end, and 10% or 5% are eliminated from the bottom end, and there's the bell-shaped curve. So realistically, 5 to 10% of animals, or 10 to 20% of animals, can be outside the normal range and it be normal for them. And so when we look at these lab values, you go, does he have a history of slightly elevated phosphorus? Do we think he has parathyroid issue? Do we think he has a diet that is skewed in its calcium phosphorus ratios? Any number of things that we can think of, we can rule in or out depending upon how we evaluate Kodiak and take a history. At this point, I think this is probably just normal for him because I exhausted all of those questions. So again, everyone gets the same type of care. They get usually Cerenia, which is meropitant, in their pre-anesthetic plan. It could be given orally the night before. That's okay. That seems to work too. Or given sub-Q the day of the procedure. Again, I have a tendency to give it sub-Q, let it sit for a while, not give it IV. Then pre-anesthetic, put the IV catheter in. This dog needed a pre-anesthetic and he needed to be heavily sedated because, of course, he is full of energy and he really is still a puppy at 14 months of age. So pre-oxygenate for 2 minutes. Why 2 minutes? This dog was quiet enough for us to get all the monitoring on after his pre-meds in about 2 minutes. Again, no rubber diaphragm on the mask. IV induction, intubation, inhalant maintenance. Everybody's going to get this. We've already talked about creating anesthesia protocols for patients. So the sequence is the same for everyone. So this is the first monitoring screen. It comes up right after induction. And we're going to start with breathing because if you can't breathe, nothing else matters. So his end tidal CO2 is 38. And I have a tendency to evaluate things on the screen when I'm looking at numbers to say, is it too high, is it too low, or is it acceptable? So I'm going to just continuously ask, too high, too low, or acceptable. 38 is acceptable. Remember, the normal range for end tidal CO2 is 35 to 45. There's always a range in biology. We can memorize a number and say, oh, 40 end-tidal CO2. That's perfect. But is anything in biology ever perfect? It's not. So everything indeed will have a range. Respiratory rate is 6. So do we think that's too high, too low, or acceptable? It looks a little bit low, but his CO2 is 38. So obviously 6 breaths a minute, he's taking a large enough tidal volume at 6 breaths a minute to keep his carbon dioxide, his end-tidal carbon dioxide at 38 millimeters of mercury, which is normal. Next, we're going to look at the capnogram waveform. And remember, the capnogram waveform should look like elephants following elephants. And so when we have the capnogram waveform, he has a nice exhalation, and then we should have a plateau that's flat. It's not really that flat when I drew it, and then come down. So we should have a nice exhalation, a nice plateau, and then for it to come down sharply at inhalation. We're not seeing this on that capnogram waveform. This particular capnogram waveform is dilutional, the way that it slopes out of the plateau. So here's the plateau, which should be straight, but it slopes away. The CO2 is getting diluted over time. So when we see this waveform, we know the carbon dioxide is being diluted by something, which is most likely a leak, and the leak will be very close to the patient. So what we want to do is to leak check the machine. So we go squeeze the bag, whoosh, and we hear the gas whoosh, past the endotracheal tube cuff. So what we're going to do is we're going to fill up the cuff, and then we're going to check again. We're going to squeeze the bag to a nice chest excursion, and we're going to listen, and we don't hear any gas escaping past the cuff. So we fixed one problem. Now we're going to look at blood pressure. His systolic is 88, which is too high, too low, or acceptable. Go, it's too low. His diastolic is 34. Go, is that too high, too low, or is that acceptable? That's also too low. His mean pressure is 48. Go, is it too high, too low, or acceptable? 48 is too low. So he is globally hypotensive. His systolic, his diastolic, and his mean pressure are hypotensive. He's just been induced under anesthesia. He was heavily sedated with his pre-meds. We've just turned the inhalant on. Is a little bit of hypotension at this point unexpected? I think we would expect it right now. Now his pulse rate and his heart rate are both the same, 111, 112. That's actually equal. It's just the difference in the number is averaging in the two techniques. But because one is being measured by the plethysmograph waveform and the other one is being measured by the ECG. So we look at those together and go, is that heart rate too high, too low, or about what we would expect right now? And I would say that's about what we would expect right now. So he is a little bit hypotensive. Do we make a conscious choice now? We're going to decide. It's a conscious choice. Do we intervene now for his blood pressure being a little bit too low, or do we wait and see where it's going in the next 5 minutes? Because we want to look at these readings and record them about every 5 minutes. That's been shown to be the optimal time between recordings to be able to recognize trends quickly. His temperature is 99.7 Fahrenheit, which is 37.6 C. Is that something that we expect? He's a little bit cooler than he was when he came in, and that's okay, but he surely is not hypothermic. So we'll make the conscious decision with his blood pressure. We'll see where it's going right now. Is it going up or it's going down? We can also adjust the vaporizer dial. We just started him on inhalant. So what was in the machine before we put Kodiak on it was actually room air. So we've just turned the vaporizer dial on. We've just induced him to anesthesia. We can check his palpebral reflex. We can check his eye position. We can check his jaw tone. We can make a choice based on too light, too deep, or just right. And if he looks a little bit deep, let's turn the initial vaporizer dial setting down just a little bit, and let's wait 5 minutes, and we'll see what the next readings are. So 5 minutes go past. We go, now, end-tidal CO2 is 43. That's a little bit higher than it was. Respiratory rate is 6. I go, that's still okay. So end-tidal CO2 is still in that normal range, which is definitely acceptable. Respiratory rate is 6. So again, he's taking big enough tidal volumes at 6 breaths a minute to be able to maintain his CO2. But look what's happened to our capnogram waveform. It still has that dilutional pattern to it. So again, we have a dilutional pattern here where instead of having a nice plateau, which is what we should have, we have that downslope, that gradual downslope that indicates dilution. So the plateau is fading away and it's a dilutional type of pattern. At this point, again, what we're going to do is close the pop-off valve, squeeze the bag, and again we hear whoosh past the endotracheal tube cuff. So now we know that we have a faulty endotracheal tube cuff and we'll have to replace the tube. How convenient is it to replace a tube while the patient is under anesthesia? It's not convenient at all, but we certainly can use an over the stylet technique to replace the tube without having to move a patient out of position. And the over the stylet technique basically is that we take a long stylet and we can make them by putting two polypropylene urinary catheters together and putting tape long ways along there. I don't have a picture to show you, so I'm just going to describe it. You put that through the lumen of the endotracheal tube, you pull the damaged tube out, you put a brand new tube over the stylet, and because it will follow the stylet into the airway, we know it's going to go into the airway. And then we'll go ahead and affix that tube into place. We'll blow the cuff up and we'll check again to make sure that there's no leak around the cuff. We have an adequate seal. The main purpose of the endotracheal tube during dentistry is to protect the lungs. Now, we have a nice seal to protect water from running down and debris from running down into the trachea. Surely, if we point the high pressure water and air sprayer down into the pharynx, it can defeat the seal of the cuff and put water down into the lungs by the high pressure spray. But just stuff that's running back there passively, it will help to keep the integrity of the lungs intact. Remember, only air in the lungs. So now, let's go on to blood pressure. We fixed the airway problem, the endotracheal tube cuff problem. We've thrown that tube away. We've put a new one in. Systolic now is 111. Now, is that too high, too low, or acceptable? Definitely it's acceptable. Diastolic is 47. Now, is that too high, too low, or acceptable? What we want to look at really is the systolic-diastolic difference and to decide if the diastolic is in proper ratio to the systolic. The diastolic should be 30 or 40 millimeters of mercury below the systolic. So I'm going to fudge the numbers a little bit to make math easier. So systolic is 110, diastolic is 50. That's a difference of 60 millimeters of mercury. Now that's much greater than the 30 to 40 normal difference that we like to see. The mean pressure, however, is 76. The only reason that diastolic would be a concern is if the mean pressure is now too low because the diastolic pressure is too low. The mean pressure is very influenced by the diastolic pressure. There's a calculated equation that's tweaked a little bit in the machines based on heart rate to create the mean blood pressure number that we see. And the equation is 1/3 multiplied by the systolic-diastolic difference added back to the diastolic. So we can see just from that equation that the diastolic has a huge influence. The diastolic pressure has a huge influence on what the mean blood pressure calculation will be. And if we look at this and we go, he's normotensive for his systolic pressure, he's a little bit hypotensive for his diastolic pressure, but he is normotensive for his mean pressure. We don't need to treat for diastolic hypotension. We're going to look next at the heart rate. The heart rate is 119 beats per minute. Now, is that higher than we expect it to be, lower than we expect it to be, or is it about where it should be? Since blood pressure and heart rate hold hands, we should always look at them together. We can't tell why one is changing without looking at the other one. So in this instance, he has 120 beat per minute heart rate, which is basically matching the plethysmograph counted pulse rate down below that. And I didn't really talk about pulse oximetry because he's on 100% oxygen. It should be in the high 90s. If it's not in the high 90s, we probably need to readjust the clip, especially if he looks bright pink, that bright, beautiful bubblegum pink of the mucous membranes when patients are on 100% oxygen. So we'll look at the heart rate and go, do we need to do any treating right now? No, his blood pressure has popped up. We fixed the problem with the endotracheal tube cuff. Thank you, capnogram, for showing us there was a leak. And then let's look at his temperature. His temperature is 100.2 Fahrenheit, 37.9 C. Now that definitely has gone up. So the question becomes, is our efforts to keep him warm, is that what's working, or is his temperature rising for another reason? Only time will tell, because if we've applied external heat sources, and especially effective external heat sources, we've covered more than 60% of his body area with the external heat source, then we would definitely be effectively rewarming him. So at 100.2, I'm not too worried. I go, oh, maybe my external heat sources are actually working. It's been a little bit short of a time to rewarm that much, but perhaps it's just the external heat source that's doing it. I don't need to uncover him. I don't need to do anything at this time. But as time goes by, and it's not the next monitoring screen, it's 2 or 3 screens down the road. So about 15, 20 minutes later, and see, we're working in his mouth. And you go, if we're working in his mouth, he should be getting colder because we're dumping cold air or cold water and perhaps cold air on the dog air conditioner. So he should be getting colder or staying the same. But we look at this next monitoring screen, and again, end tidal CO2 is 43, respiratory rate is now 10, so he's a little bit lighter under anesthesia, or his respiratory rate is picked up for another reason. Capnogram waveforms look like elephants following elephants. Systolic 119, diastolic 58, mean 82. The systolic-diastolic difference is still a little bit wide, so we would technically call that diastolic hypotension, but his mean pressure is fine. So we don't have to do anything about his diastolic hypotension at this point. Heart rate's 130, so his pulse rate's 130, he's matching there. SpO2 99%, beautiful. Now his temperature is 103.1, which is 39.5 C. At this point, we need to start making some choices. Go, well, are we cooking him? Did we just apply too much external heat source to a dog who is going to create a lot of heat on his own? The Nordic breeds of dogs are made genetically, physiologically, to live in these sub-zero temperatures and to keep themselves warm when there is a lot of cold air surrounding them. Their whole environment is literally freezing, and these dogs function and they work and they live in this environment. So their bodies are programmed to create a lot of heat to keep their bodies warm. And also their coat is very insulating. So the heat that's made inside their body doesn't leach out into the environment as much because their hair coat is made to insulate them. Granted, we're pouring cold water on the dog air conditioner, which is his tongue. However, he is still getting warm. So our choices are, is he getting warm because we're cooking him? We've over-applied external heat source. Another choice could be he's a Nordic breed of dog. He could get warm under anesthesia because he's not able to cool himself like he normally would. Now, we think about that and go, we're pouring cold water on his tongue. But how much cold water is actually going on his tongue right now? Because we're working on that chipped tooth. I'm not sure exactly what was going on, if they were just doing odontoplasty and bonding it. I don't think he had a root canal. I think that's all they had to do, and then we cleaned up the rest of the teeth. But in any case, choices are, we're cooking him with external heat source. That's why his temperature could be rising. He could have drug-induced fever. So it's a pharmacologic type of fever. So when we administer certain drugs like ketamine, like the opioids, like the alpha-2 agonists, medetomidine, dexmedetomidine, those can actually go into the thermoregulatory center in the brain and reset the temperature. So the brain goes, oh, my new temperature is 105, and the body heats up to 105 or 104. So that's my new temperature, until the drugs wane enough for the thermoregulatory center to say, oh no, I'm not supposed to be this hot. Let me cool back down to my regular body temperature, which is 99.5 or 100.2 or whatever it is for that individual patient. So at this point we go, he could have drug-induced fever. And then of course there's that dreaded malignant hyperthermia that can happen to any patient, but it's exceedingly rare to see in our practice career. When we have malignant hyperthermia, which is a huge metabolic event in the muscles, it's uncontrolled muscle metabolism, and it will throw out a whole bunch of heat, will heat patients up, but it also, because it's created in the muscle, will throw out a whole bunch of carbon dioxide. Carbon dioxide in this case is normal. So I'm not worried about malignant hyperthermia. It could be that he has drugs that have reset his thermoregulatory center, and he has a pharmacology-induced fever, drug-induced fever, or we could just be cooking him. So let's uncover him from the thermal sources that we've applied to him. And if he remains hyperthermic into the recovery period, we might think about reversing some drugs that could be the culprit. If it's ketamine we think is the culprit, then perhaps we need to just let that wear off. Do we have to start dumping cold water on him? Do we have to start putting alcohol on his feet? I don't think so. 103.1 is really not that hot. So this is where the Nordic breed of dog is made to live. And this is actually funny because I think he is looking pretty relaxed in the refrigerator. And then most of our patients in the OR, though, feel like this bunny and they're in a refrigerator. The surgeons always complain, I'm hot. So they're covered in surgical garb. They're underneath hot lights. And the dentists are no different. They have a towel on their lap because of debris and spray from the working area. There's usually some type of device on their head for magnification and light. And they're working in an area where they're probably getting hot air blown on them from thermal support sources. And so usually the room is pretty cold. So our patients feel like they're in the refrigerator most of the time, except the Nordic breeds of dogs, which will be really happy to be in a cold place.
I hope you enjoyed that episode with Dr. Lukasik. There is a link in a promo code attached to this podcast that will allow you to get a large discount on her course and also any of our dentistry courses. We'll see you next week.